Please join me in welcoming the team from Infectious Diseases to educate us today on antimicrobial stewardship. Thank you.
Thank you very much for having us. Most of the discussion today will be led by Dr. Faulhaber and then by Nathan, Dr. Everson. Again, thank you for having us. You can go to the next slide. And next, these are our disclosures. Next slide. So, over the course of this talk, Dr. Faulhaber will describe the benefits of an outpatient antimicrobial stewardship program using a case to highlight the importance of this concept. He will identify barriers and concerns regarding outpatient antimicrobial stewardship, and then how we can incorporate antimicrobial stewardship into our daily practice. And then we will go on to describe a process which we are trying to develop within Carilion Clinic in the outpatient setting. So, Jason, I thank you for agreeing to do this.
Good morning, everyone. DJ, you can go to the next slide. So this is just a preview case. So we have a 3-year-old previously healthy child who presents as a walk-in to the general PIDS office with a 2-day history of a cough and a fever up to 113. He's well appearing and well hydrated. He has a respiratory rate of 44 breaths per minute, and he has mild intercostal retractions. Crackles can be appreciated over the right lower lobe on auscultation. Rapid PCR testing is negative for influenza A and B, RSV, as well as SARS-CoV-2. His immunizations are current. There are no known sick contacts. He's in group daycare in a neighbor's home with 3 other children aged 2 to 6 years. He has no known allergies to medication, and he was last treated with amoxicillin for acute otitis media 9 months ago. Okay, next slide. So this is a cute little cartoon, because we're nerds, about Halloween and how scary it can be to be have antibiotic resistance from an unfinished course of antibiotics, and consequently, Beatrice was never invited to a Halloween party ever again. Next slide. So antibiotics are the most commonly prescribed class of medications to children. A vast majority are in the outpatient setting, looking at about 20% of ambulatory care visits result in some form of an antibiotic prescription, which corresponds to about 15 million prescriptions annually. And acute respiratory tract infections are the majority of the source of prescriptions, accounting for more than 2/3, which is more than 10 million unnecessary prescriptions prescribed every year. Exposure for antibiotics obviously can lead to resistance, as well as C. diff as complications, and drug-related adverse effects, and there are a variety of those. Not just simply rash or allergic reaction, but also end-organ toxicities. And the CDC estimates that antibiotic-resistant microbes account for nearly 3 million infections and over 35,000 deaths annually. And if you include C. diff in that, then it's more than 3 million, and it's about nearly 50,000 deaths annually. Next slide. This is a map from the CDC, which is representing the prescriptions per 1,000 population by state. The darker the color, the higher the rate. And you see Virginia there, we're kind of in the middle. This is in 2014, 266 million courses of antibiotics are prescribed. This equates to more than 5 prescriptions written each year for every 6 people in the United States. And close to 30% that were prescribed were unnecessary. So that's a significant population of prescriptions that are unnecessary, and consequently adverse effects are possible. Next slide. This is Virginia. So we see that prescriptions vary within regions. We are in the green region, so we account for 30% of the prescriptions for upper respiratory infections within the entire state of Virginia. And the majority are going to be, well, of prescriptions are in the outpatient setting, and nearly 80–90% of antibiotics are consumed from the outpatient setting. And the most commonly prescribed are azithromycin and amoxicillin. Next slide. So we know that there is overprescribing, and we know that that is what drives antimicrobial resistance, especially in the pediatric population. We know that kids seeking care in both the suburban and rural areas have higher rates of treatment for viral infections, as well as higher rates of treatment that are off guideline for and broader spectrum for those that actually do warrant antibiotics. And there are a lot of factors that play into this. Parental pressure is certainly significant. The fact that there is some feeling medical liability in the context of potentially life-threatening infection. Diagnostic uncertainty, not necessarily knowing exactly what we have, especially if we don't have the ability to test. Fear of increased morbidity and mortality, obviously you never want any harm to come. And fear of poor patient satisfaction has also been listed as a potential factor. Everyone wants to be liked. Next slide. So antimicrobial stewardship basically is just giving antibiotics when they are necessary. And they are necessary at times, obviously, but when it is necessary to prescribe, the keys are that you target the spectrum of activity to the organism that most likely is causing the infection, unless you do have a positive test result. Using appropriate dose, route, and duration of therapy. And duration of therapy is concerns here. You're making sure that we have found that shorter courses for a variety of medical conditions are actually just as good as longer courses, and shorter courses would limit the potential for development of resistance. And the goal is obviously to optimize outcome while minimizing the undesirable consequences and adverse effects. And antimicrobial stewardship programs reduce antibiotic overuse while improving patient outcomes, and this has been proven in multiple studies. Next slide. So these are different core elements. So you've got commitment, so demonstrating dedication and accountability. Action for policy and practice, so developing at least one policy and implementing it within the practice to improve prescribing. Tracking and reporting is very important because you want to make sure that you actually are making a difference, not just saying that you're going to do something, but this at least allows you to monitor. And then education and expertise, educational resources to both clinicians as well as to patients and family about prescribing and when is it necessary and when is it not necessary. Next slide. This is from the CDC, looking at little checklists that they have available. On the left-hand side, the checklist is for the clinician, and on the right-hand side, it is the checklist for for the clinic, for the facility that you're working in. And this is just to give you, again, looking at those 4 different core elements and asking questions. Are you able to do this, or have you done this? And this is a checklist just to make sure that you're on the right track. Next slide. The AAP and the Pediatric ID Society have a whole list combined of recommendations. This is pretty wordy, but the baseline, the bottom line of this is just that you need to have some form of an antimicrobial stewardship program in order to regulate and monitor and improve antibiotic prescribing. And it should include specialists who do have pediatric experience. It doesn't necessarily have to have somebody with infectious disease experience, but obviously that is helpful. with regards to antibiotics. It does mention other individuals, including the use of pharmacists, as well as nurses, as well as other stewards, and for example, like physician champions. And it's really looking at from the outpatient stewardship to focus on specific targets. So upper respiratory tract infections, non-streptococcal pharyngitis, for example, urinary tract infections, and of course acute otitis media. Next slide. So we very briefly talked about some of the unintended consequences. We talked about drug resistance, and MDROs cause about 5 to 10% of healthcare-associated infections in children. And we know that there is an increase in the rate of MDR, especially outpacing the new development of antimicrobials that could be used for treating them. Adverse drug events account for nearly 50% of all ER visits for children. And C. diff, obviously, so 71% of children in one study were community acquired after exposure to antibiotics, and that there is a 3 to 8-fold increased risk of developing it if given an inappropriate antibiotic for infection. You know, we traditionally think of C. diff more so, obviously, in the adult population, but the pediatric population gets it as well. The younger kids, we tend not to think so much of it just because from a colonization perspective and less likely to cause actual infection, but certainly with increased exposure to antibiotics, then it is definitely a possibility. And then dysbiosis, intestinal, so we always recommend doing some form of probiotics. We know that imbalance in the gut can have impact on other systemic disorders, including diabetes, juvenile idiopathic arthritis, IBD, as well as asthma. Next slide. So we have a variety of different strategies, and we're going to go more into this with what we're doing. Clinical decision support, basically supporting others having a specific guideline for the clinicians. That can also include auditing with feedback of antibiotic prescribing. So looking back and saying, hey, you did a good job, or instead of doing this, you could have used this antibiotic or not use antibiotic at all. Clinician and or patient parent education, which does include watchful waiting. It also includes in that setting looking at delayed antibiotic prescribing, which does form, kind of a shared decision making. So basically providing them a prescription, but saying don't fill this unless A, B, and C happen. So either we get a positive culture result, things get worse, etc. Implementing a systemic approach, following up with especially culture negative results. So say, hey, all right, the culture is negative. They don't really need to continue on antimicrobial therapy. Communication training, which includes training the clinician to be able to communicate nobly with parents and the patient, and how to discuss, yes, we need to use antibiotics. No, we don't need antibiotics in this case. And says looking at unnecessary prescribing, what is the best choice, and then obviously looking at duration and route of therapy. Next slide. So this is just looking at, so say this, Gerber is one of the clinicians who's actually big into antimicrobial stewardship in pediatrics. And this was looking at a broad spectrum antibiotic prescribing for looking at including a 1-hour clinician education session, as well as personalized audit and feedback that was provided every 4 months, followed out for 12 months. There were 18 eligible practice groups, a total of nearly 1.3 million office visits by over 180,000 unique patients. And as you can see, the control being in the open circle and the intervention being in the darkened circle, and that there was a larger decrease in the intervention group, showing from 26.8 down to 14.3%, so nearly half. Next slide. This was broken down into individual types, looking at pneumonia, sinusitis, as well as group A strep pharyngitis, and still see that there was drastic changes, notably in pneumonia as well as sinusitis, where it dropped from 15.7 down to 4.2% in pneumonia and 38.9% down to 18.8% in sinusitis. Paul asked a question: is there data to recommend probiotics with every antibiotic course in healthy kids, and when? There are specific data. I'm not entirely sure of very specific data for pediatrics alone. Maybe Nathan can contribute to that, but I would say that we recommend it for everybody just because of the known causes of or concern for dysbiosis. And there isn't really one probiotic that is necessarily better than others. I mean, personally, what I tend to recommend is really just yogurt. That's usually sufficient. There are a whole variety of probiotics that are available, some prescription-based, but even those are less commonly prescribed, and most of them are just over the counter.
Jason, it's Nathan. I definitely back up what you're saying. I think the single strain probiotics you can get over the counter, like lactobacillus and stuff, are probably not that useful. I also don't think that giving them while they're on the antibiotic is probably that great either, because most of the things are easy to kill and your antibiotic is probably taking out what you're giving. But after finishing a course, something like yogurt, kefir, or something like that would be excellent options.
So the CDC has several pamphlets, handouts, and posters with regards to this whole campaign of Be Antibiotics Aware, Smart Use, Best Care. And so this is just showing you a couple of examples through these next few slides. So, if you have an infection caused by virus, antibiotics are not going to make you feel any better, and that they aren't always necessarily the answer when you are sick. Next slide. So this is the other part of it. So there, like I said, there are a whole variety, and you can have these available within your office to be able to provide to the families, so that way they can have a better understanding as to why you're promoting stewardship. Next. And here's looking at, I'm specifically looking at questions, so looking at the common conditions, the common cause, whether it be bacteria, potentially bacteria or virus, and then whether or not antibiotics are indicated. And this gives you a nice visual for the family to be so like, okay, she has A, B, and C, and okay, that looks like, oh, well, no, it doesn't need antibiotics. Okay, so now I have a better understanding. And also allows for discussion with the family. Next slide. So communication, this is again what we're talking about, communicating with the patient/parents and family. And the key to all of this also is just sustained ability. So this really does need to be continuous to do. So continuing with training, and this becomes important obviously when there's rollover within a practice, or as new residents are coming in, for example, that you just have continuous training about how to have these discussions with family and patients about whether or not it is necessary to use antibiotics. And we can see that it has the ability to reduce unnecessary prescriptions by half and to sustain for over a 3-year period. Next. There is a phenomenon called Handshake Stewardship. This was first published in Colorado Children's Hospital. It was really used as an inpatient antimicrobial stewardship, and what it allowed for was in-person, face-to-face rounding and interaction, being able to discuss why you're using a certain antibiotic, or is it necessary. And this showed that there was a decreased overall antibiotic day of therapy, which is what they use, total days of therapy, by nearly a quarter over a 5-year period. And this is something on the adult side we do. So on infectious disease team for inpatient rounding, there's a pharmacist And so we do something very similar to this. And so there's a lot of discussion as to why we want to use certain antibiotics, if we even need antibiotics. Other testing needs to be done, and then communication with the primary team. Next. And this is just a table looking at different methods to incorporate into antimicrobial stewardship, the advantages versus disadvantages of these. I'm not going to go through all of these, but this really goes through different examples as to what we use. Sorry, Michael, I'm just reading what was posted. Yeah, I would say that we actually don't really stagger antibiotic and probiotic administration. I mean, I usually don't. I mean, obviously, there's certain antimicrobials that you shouldn't take with yogurt directly, or anything that's calcium-based, for example. But we usually supplement throughout. So, and there are certain antimicrobials, depending on how often they're prescribed, it's kind of difficult to be able to truly fully separate from giving the probiotic. But I mean, I agree. I don't think that it's necessary to completely separate them, if that's what you're referring to. Okay. Next slide. So this came through the recommendations that were just released last year, and looking at different gaps that we have that we need to kind of focus on in order to improve antimicrobial stewardship all throughout. And so it's basically coming up with a specific organized structure and interventions for both ambulatory as well as acute care setting, understanding that there are cultural and adaptive influences that need to be addressed. How best to incorporate nursing, because obviously nurses are also a front line for administration of antibiotics, as well as having good rapport with the family and patient. Defining the optimal treatment for common infections. So this is going to guidelines and looking at clinical decision making. Developing and validating metrics to consider the potential harm of antibiotics and weighing them against the risks, and weighing the risks and benefits against that. Establishing risk-adjusted antibiotic use benchmarking approaches and being able to monitor. Approaches to effectively teaching clinicians in order to become self-stewards. We at Carilion had the Carilion Infection Disease Pharmacy program had developed a whole stewardship program, and so Nathan can talk about some of that before. So we I still have my little pen that's a steward. It says being self-stewards. And then incorporating patient and family perspective into shared decision making. We talked about this, about looking at delayed prescribing, for example, but really more from educating the patient and family about the need for antibiotics. Okay, next slide. So going back to the case and looking at an example of what to do. So just as a reminder, we had a 3-year-old previously healthy child presented as a walk-in, has a 2-day history of cough and fever, it's 1013, is well appearing, appears well hydrated, breathing at 44, has mild intercostal retractions, does have crackles over the right lower lobe. Rapid PCR testing is negative for the main viruses. His immunizations are current, no known sick contacts. So next slide. So what is the most appropriate next step in managing the child? Should you obtain a chest x-ray? Do you prescribe a 5-day course of high-dose amoxicillin? Do you prescribe a 10-day course of clindamycin? Do you administer a dose of ceftriaxone IM and then prescribe a 3-day course of azithromycin? Or do you provide no antimicrobial therapy, as this is most likely viral and he is clinically stable? So we have at least one vote for E. You don't have to put in those in your answers if you don't want to.
In the room, we're going with
it's just
E.
kind of like more to think about it.
I don't know if you can
So
hear
of
us.
course, obviously, since this is an antimicrobial stewardship, you want to go with E. Obviously, you shouldn't use antimicrobial therapy. So yeah, viral is certainly a possibility. So remember going back to him though, like he is 3 years old. He definitely does have evidence of pneumonia. And so even though he's quote, clinically stable, I mean, there is something. He definitely has crackles there, and it probably would be prudent to go ahead and treat. Chest radiograph is not necessary. The question is that if you are going to treat, what is the best option for treatment? Again, so this is looking at stewardship. So do you do a 5-day course of high-dose amoxicillin? Do a 10-day course of clindamycin? Do you give IM ceftriaxone and then a 3-day course of azithromycin? So again, you're looking at targeted therapy for what you're thinking the major organisms are, as well as duration and administration. And so based on this, Dr. Eames, who is so smart and loves me so much, B, prescribe a 5-day course of high-dose amoxicillin. So you can turn next slide. And the next to go through explanations for. So chest x-rays unnecessary based on the physical exam findings. A 5-day course is appropriate length and it does have narrow spectrum. A 10-day course of clindamycin, inappropriate length. I don't need a 10-day course, and also has increased risk of side effects because of the clindamycin. The same thing for the IM ceftriaxone and 3-day of azithromycin, inappropriate spectrum. And yeah, although it may be viral, he tested negative for the 3 main viruses they'd be most concerned about, and so therefore bacterial pathogen is probably more likely. Yes, it wasn't an RVR, it wasn't looking at all of the viral possibilities, but given this, that bacterial was certainly probably a little bit more likely than viral. Next. This is going to be our segue into pharmacy. So pharmacists are absolutely integral to the success from an antimicrobial stewardship program. They are recognized as leaders by a variety of different programs available. Review antimicrobial orders, so they're able to help determine whether or not medications are appropriate. Yes, this is, sorry, I'm going back to the chat. Yes, the RVIR doesn't test all viruses either, true, but looking at the major viruses. And do I think that changes in coding in ambulatory settings promotes prescription drugs used since higher coding? That I don't know. I don't know if I can necessarily comment on that, because I don't really, personally, I don't really look at the differences with the coding, so I can't speak to that, but maybe one of my colleagues could speak to that further. But pharmacists also help with developing guidelines and being able to select alternate agents, especially if there is a known adverse event, effect or allergy. They can provide guidance and education about the medications and real-time feedback for adjustments based on any of the data that we get. Another comment, will there ever be a time when choice F, procalcitonin, will be an option, for example, if it becomes a rapid and affordable test? So procalcitonins are not generally recommended from an infectious disease perspective. We're not big fans of it, mainly because of the limited utility in it, especially with any positive test. It's very useful for negative, but from a positive, it makes it a little bit harder unless it's extremely positive. So it's very good on extremes, not so much in the middle. And we think that it's often misused, basically overused in trying to determine whether or not something is viral versus bacterial, because there can be variability in the test results. So I'm going to pass this off to Nathan to talk about antimicrobial stewardship from the pharmacy perspective.
Hey everyone, thanks for the opportunity to talk to you all today. I'd also like to make a comment about the procalcitonin there. Europe's actually quite a bit ahead of us when it comes to doing some of these tests in point of care and clinic. So CRP and ProCal are used at different places in Europe. They actually do a lot of like chest ultrasounds and stuff too, and avoid having to do x-rays for pneumonia diagnoses. But particularly for like upper respiratory or pneumonia stuff, using ProCal point of care, I think has like a lot of potential because it really helps early on in decision making and if you get the result back fast. So I haven't even gotten an answer if we have options of ProCal in the clinic at point of care. It's something we've been looking into with our new grant. So great question. Don't have a wonderful answer for it yet, but hopefully we'll have some stuff eventually. Next slide, please. So the Antimicrobial Stewardship leadership at Carilion Clinic, we have Dr. Baffoe-Bonnie, who's our physician co-lead, and then myself and Lauren McDaniel. I've recently transitioned within the last year and a half to the ambulatory setting and kind of trying to start our ambulatory antimicrobial stewardship program. And then we have Lauren McDaniel, who's our inpatient lead and runs our system antimicrobial stewardship subcommittee. Next slide, please. So this is our subcommittee that meets every 6 weeks. Almost all of our ID physicians attend, as well as our ID pharmacists. We do have, of course, Dr. Faulhaber, who you just heard from, and Dr. Nowak, who are our experts in pediatric ID, and who are kind of essential for any pediatric guidelines that we're working on. We do have a pretty strong pediatric representation, so from a pediatrician, pediatric intensivist, as well as a neonatologist. And then we, of course, had Nikki Rosette as our pediatric pharmacist, who has left us recently, so we'll be filling that role pretty soon. And then we have, hospitalists, surgery, infection control, emergency medicine, micro-nursing. We cover both inpatient and outpatient, though we are looking at developing a specific ambulatory committee as we continue to move with our ambulatory needs throughout the system. Next slide, please. So AMS is definitely hard to implement in the outpatient setting. A lot of our interventions that we make on the inpatient side are, direct patient interventions. When we have 220, clinics spread throughout Southwest Virginia, it's really difficult to do any sort of patient-specific interventions. So a lot of what we're doing is creating resources, trying to find ways to get the resources into the hands of the clinician at the point of decision-making, and kind of creating tools that can help people in the visits themselves. So the CDC created the recommendations for outpatient stewardship are really generic because I think they're very early, since it's still kind of an area that stewardship is kind of finding its feet and what kind of best practices are, which means Carilion Clinic is poised to develop a lot of best practices in both pediatric as well as adult outpatient stewardship. We have the volume, we have the engagement, so we're really hoping that some of our efforts can kind of help shape best practices for the future. Next slide, please. Measuring is probably the area that we've been focusing on the most recently. So kind of looking at how we're going to track use of antibiotics, what's the best way. The data supports all kinds of different approaches, whereas inpatient, we use days of therapy as kind of our standard measure of antibiotic use. It's reported to NHSN and benchmarked, but outpatient, we don't have that same type of standardized measure. So there's a lot of different things we can look at, and a lot of them are kind of detailed here. I think number of antibiotics prescribed per patient visit is a big one. We have a very large dashboard in development that will capture a lot of this. The goal is eventually for this dashboard to be usable by the end clinician, who can then look at their antibiotic use and potentially even compare it to others, is our kind of end goal there. Next slide, please. So tools that we have for you all as kind of actionable items. We have our Antimicrobial Stewardship Hub on Inside Carilion. I know Inside Carilion isn't the easiest thing to access, particularly when you're kind of in a rush, and particularly if you're not on site. We do have many inpatient, outpatient treatment guidelines, and we have pediatric recommendations for the vast majority of them. And that's been a big focus in the last 5 years, is making sure that everything we're making has some sort of pediatric inclusion, if at all possible. We are looking at some ways to make these guidelines a little bit more available, potentially even in Epic, because going out and going inside Carilion can be kind of a pain for anybody. We have ambulatory e-consults for antimicrobial stewardship. There are 2 different infectious disease e-consults, one to the providers and one to the pharmacist. If you're going to use the pharmacist one, there's no cost to the patient. I'd recommend it for drug selection, side effects, dosing. We're also really good at pulling in our ID physician colleagues if it's outside of the scope of what we're comfortable with from a diagnostic standpoint. I'd say our average consult is addressed within 24 hours on a Monday through Friday situation. That's the consult there. And if you need a more timely answer, we do have a perfect serve call schedule that's staffed 8 to 4, 7 days a week. So there'll always somebody be there to answer a question if you need more of an acute response. Often that will be coming towards me during the week, but may sometimes be some of my other colleagues. Next slide, please. So these next 2 slides are just a couple examples of things that tools we've made for people. This is a viral symptom relief prescription. So the goal for this is that you can kind of give somebody something that they can walk away with to help them feel like they've gotten something from the provider, as opposed to leaving and saying it's just viral. We have a children's as well as an adult version. They've been around for a couple of years, but we haven't actually had them printed out and disseminated to clinics, which is our plan for this year. So just kind of an example here of what you can kind of walk through the patient and check the things that you want them to do for their symptom relief and give some of that guidance. So they're kind of walking away with a kind of an action plan for managing that URI. As opposed to necessarily getting antibiotics if you feel that it's more of a viral situation. We are also experimenting with a treatment or symptom relief packs that would be like nasal saline and lozenges and that sort of stuff that we're going to try out some of our urgent cares potentially this year. Again, with the same goal of patients walking away with something, and if that kind of helps with that patient expectation of an antibiotic. Next slide, please. And just another example of some of the stuff that we have on our intranet. This was made a few years ago in conjunction with some PIDS physicians, and it looks at otitis media. It's an algorithm to try to make things easy and that you can kind of run through pretty quickly with all the recommendations in just 2 pages. So I'm sure some of you have probably seen it before. Something else that Nikki Rosette worked on with us. My goal is to eventually get these sort of tools in Epic. I recently, within the past year, got physician builder status with Epic, and my goal will be to help create some actual like visits and things that have a lot of this kind of pre-programmed into the visit. So there's less documentation on the clinician side. All of the things you need are right there, right in the visit, and you can spend more time focusing on talking to the patient and less worry on the Epic side of things. So hoping that sort of thing we can look forward to in the future. Next slide, please. So kind of looking down the road for ambulatory stewardship, the dashboard, which I discussed already, is in active development. We hope to have at least a first version of that done by March, maybe a little bit later. We're looking at education pearls, creating that for the health system, and this is also as part of our recent grant. So it include didactic presentations, short videos. I have not convinced Dr. Faulhaber to do TikTok dances with AMS teaching pearls, but we might get there. and then potentially some podcasts as well with different providers about different issues in the ambulatory setting. Looking at enhanced EPIC tools, as mentioned already, but we also really want to hear from you guys as well. Do you have preference lists that are garbage, and it would be a lot better to have different entries in your preference list when you're ordering an EPIC? Classically, ambulatory preference lists need some love in most places. Is there anything on the IT side? Is there anything on the educational document side that you think would be really helpful? So the Antimicrobial Stewardship email is always a great place to send those sort of suggestions and feedback. And we'd love to hear from more ambulatory clinicians about what kind of things we can do to help support and make your practice better. I do want to comment on Dr. Hart's comment from earlier, and honestly, I didn't know that they had some of that internal data with the lack of kill of the probiotics. So I think that that's pretty fantastic. I think from my angle, the most important thing again is to have a probiotic that has multiple organisms in it. The single strain, in my opinion, from the data, don't seem to show much of anything, whereas there is some data with complex strain that there might be some involvement there. Also, if some people might be aware that we recently have a kind of a fecal transplant equivalent that just got FDA approved 2 weeks ago. And I think we're going to see a lot of interesting development from that. Obviously, it's initially for CDI, but other kind of bacterial reconstitution data, I think, is going to come from that, and we may have a little bit better understanding of the best way to kind of restore someone's flora after antibiotic use. So I think in the next several years, we'll get some answers that I think everyone's been searching for a while. And I believe that's my last slide. I think the next slide is the grant slide, I think. Oh, take-home messages. So antibiotics are critical for serious bacterial infections. They've been associated with harm. AMS can improve patient outcomes by ensuring the most effective antibiotic is prescribed, only when necessary, and for the shortest effective duration. An organized AMS program can help keep clinicians up to date with best practices, improve teamwork and communication, and as well as improving patient satisfaction. Carilion has an existing AMS team. We've had a program since 2006, so it's been around for quite some time, a lot longer than other hospitals. And then, kind of keep on the lookout for future resources from us, and definitely send us ideas and suggestions. Next slide.
So I'll end with the presentation by thanking Dr. Pierce and your team for inviting us to share our ideas about antimicrobial stewardship. Actually, the pediatric providers across the US are known to have to be ahead of the game in terms of antimicrobial stewardship in the US, based on data from CDC that shows a decline in inappropriate prescriptions over X amount of years compared to adult providers. The current grant, part of what we will be using it is for communication, like what we are doing now amongst different groups, collaboration, making sure we have champions within your teams. So if you identify a champion who would want to be an antimicrobial steward, let us know, because change really comes from within, and that's simple. The change really has to come from within, and we want to make sure we have your champions who will help us move this. Then you got to know where you're going, and that's why dashboards and data is important, and democratization of data such that you can look at your own data compared in an anonymized way, of course, with your peer for certain disease conditions. That really does sustain any process, and our hope is this grant can help us build those tools. You can then use that data and that information actually create your own interventions. So, if there's a resident fellow who is looking for sort of research or even maintenance of certification type, points, using the data we have, we will have, should be able to help guide some of these things. Then you use that data again to see whether we have improved, i.e. the feedback, and then the follow-up and then reassessment. Essentially, this is called the C-diff method, kind of an interesting name, C-diff method for providing feedback. So very grateful for this team, and I'm sure very soon you'll be seeing some videos from some of our team members, your team members, related to why they think antimicrobial stewardship is the way to go, and what we are doing about it. Thank you very much. Next slide. Yes, I guess these are the references. Again, Jason and Nathan, I have to thank you for putting a lot of this together. Really grateful. And we are open for questions.
Dr. Baffoe-Bonnie, I don't know if you can see or not, this is Chris Pierce. You are welcome anytime to our things. I don't have a question as much as a couple comments. Great presentation, and there was a question about reimbursement, and the question there is, I know that had come out with the coding changes. If you do have questions, reach out to the coders, because my understanding is whether you press the button to send the antibiotic or not send the antibiotic, even though they're in our calculator, it says prescription or not, it's really not a dramatic difference or change on that. The other one, the dashboards sound great, and it's interesting. I'm just going to mention from the administrative side for folks to know that, our insurers, our payers already have dashboards. Many of the insurers are using different quality measures, HPV being one, pharyngitis, whether you're treating or not treating. And what this impacts is whether we get money as a system at the end of the year. So basically, meeting these measures, meeting these antimicrobial stewardship goals is impacting fiscally. If you were in solo or private practice, it would directly impact there. So whether you prescribe or not, that's a different viewpoint on there. But just a comment. And I promise I'll get you that video, Anthony.
Thank you very much. Thank you very much. And yes, your comments are very true. So some will actually try and look into the HEDIS data set. Some insurers actually have that, which has a lot of data on all of us and what we do, and they use it in their dashboards as well. So there are some things out there, and our hope is that we can mirror some of it, or maybe even get some of that type of information. Yeah, thank you. There's a question from Emily. Any idea why California's AMS rates are so much better than other states? I do not have any. I don't have a good idea why that would be the case.
I've got some thoughts, Anthony.
But I'll share something, and then I'll hand over to Nathan as well. So, and then maybe Jason may chime in. I'll just share. I won't answer this question, but I'll answer a separate question. The politician in me. So when you look at the data for antimicrobial prescription in the US, they found that Northeast California, Northeast California, markedly less prescriptions against the South. And there is the thought of, there are many thoughts around why that is the case. Some of it has to do with the education of the population in terms of antibiotic need or use. Is there pressure from the populace when they come and visit the doctor? I need to get antibiotics. I have a case in point where when I worked as an internal medicine doctor in Nevada, this is one or 2 days into right out of residency. I'm in this small town in Nevada, and I get this kid come to me with probably an ear infection or something, or throat. I can't remember the exact infection they had, but they had something that I was going to write an antibiotic for, probably amoxicillin for 5 days and call it a day. Now, this family looked at me as though I were from Mars. And they kept on saying penicillina, penicillina, penicillina. So I went and asked my colleague who had been in the community for a while. And the colleague said, wait a minute, you have this infection, you got to give them penicillin shots every day for 7 days or 10 days. That's what they want. Otherwise, nobody's going to come and, our business is going to go down. So sometimes the community can be a big thing. And that's why part of our grant has to be community facing in terms of educating about the need or lack of need of antibiotics to decrease that pressure on providers. Nathan, please go ahead and.
Yeah, I think it's definitely there's some community education that's been done. Also, AMS programs have been required in institutions in California for, I think, at least 10 years, potentially longer. The Joint Commission required AMS programs for hospitals and clinics, I think, max 6 years ago, maybe more like 5. So California's been well ahead of the game. I think a lot of California's requirements were used to create some of the Joint Commission, but even then, California's state requirements are much stricter on what hospitals and health systems need to show that they're doing for antimicrobial stewardship than even the Joint Commission is. So I'd like to believe that effort has a significant impact on the state as a whole due to their kind of extra regulations and extra kind of focus on AMS. But I think that's coupled with a lot of direct to the public education that the state has done over the years. So probably a multifactorial answer, but the answer I'd like to believe is they've had AMS programs for a long time.
This is Brenna Keene. So with Outpatient Pediatrics, I wanted to make a comment and a question, I guess. I'll never forget, like last summer, I had a kid who, of course, mom, they're about to go on their beach trip for the summer, and he had a viral URI, and I did not prescribe antibiotics inappropriately. She was very angry. She wanted to give the antibiotics before the trip, etc. And we deal with this all the time. So she stormed out of the office and told me she was going to go to XYZ, where she knew she would be able to get the antibiotics. And parents know like which offices, which providers they'll be able to get antibiotics from when they want them. Specifically for the urgent care setting, like we see a lot of urgent care follow-ups when we can't get them in for sick visits, in a timely manner. Miraculously, half the time, I feel like when I'm seeing a kid, they were prescribed amoxicillin 5 mLs TID, no matter the age or the weight of the kid, from the urgent care setting. Like I would say maybe 50% of the time in follow-up from an urgent care setting within Carilion, it's inappropriate dosed for amoxicillin. Is there any thought about like targeting the urgent care setting specifically within our system or systems across the country, because that tends to be a place where parents, know and expect to get antibiotics when they present?
Yes. So the stewardship grant and what we're going to be doing is going to target, or not, I wouldn't want to use the word target, it's going to include urgent cares, family community medicine, internal medicine, pediatric as our initial areas. And the comments you gave about a family member or a parent storming out is very real, and it can be probably one of the most difficult things to do when you're a provider. There is some data on when you read on antimicrobial stewardship strategies that work, there are some data on this preemptive counseling around, okay, this may not work, and then you add on, and this will likely work in terms of these are some of the supportive things that will work, like what Nathan showed in terms of that PAD. And then there is also data on how sometimes delayed prescription can also be added into it. A lot of this is really, a lot of this is communication. You're only going to be 100% right, or you're not going to get 100% patients saying, oh yeah, you told me everything, I'm going to follow. Nothing is 100% in life. But that movement towards preemptive advice, delayed prescription, or delayed utilization of antibiotics can be helpful, whilst we also work on community communication. We'll always have that problem of what about the shop next door? What are they doing? And therefore, are people going to that area? That's going to be a difficult one to sort of solve. And we'll look to your teams to give us some advice there. Because at the end of the day, when we have resistance in the community, it affects all of us. Thank you for that question. And we have we have a good number, some votes. Dr. Jason Faulhaber will do a TikTok dance video as well.
I'll have to download TikTok for that one.
You'd love me seeing it.
No, I've heard.
That's a wrap. Thanks, guys.